awards. He was awarded Swarnlata Punshi Best Researcher Work in 2002, Colonel Rangchari Award in 2009, Distinguished Ophthalmologist Gold Medal from Uttarakhand Ophthalmic Society in 2012. He got Dr. P. Siva Reddy Oration Medal in 2013, Dr. M. G. Bhide Memorial Award, and Dr. Samar Khwas Award in 2016. He was also awarded by American Society of Retina Specialists in 2017. He was awarded Chirag Bhatt Memorial Award in 2018, Sudha Saturia Award in 2019, and Best of IJ Award in 2019. Dr. Kasinathan is a very senior retinal specialist. He completed his MBBS in 1995 from Annamalai University, his diploma in ophthalmology in 2000 from Dr. MGR Medical University. He went on to pursue VR fellowship from Shankara Nethralaya from 2001 to 2003. He completed his FICO in 2002, DNB Ophthalmology in 2004, and also completed advanced VR fellowship from NHS UK from 2007 to 2008. He has a long experience. He worked as a consultant in Shankara Nethralaya from 2003 to 2011. He worked as department head of VR services, Vasana.
I guess we lost.
Dr. Anju?
I guess we lost the voice.
Dr. Anju, can you hear us?
2011 to 2015. He's currently, she went on to pursue VR fellowship from Dr. Agarwal Eye Hospital, Chennai. She has more than 6 years of experience in the field of vitreoretina with 700 plus surgeries. She's a member of various ophthalmic societies, and she's currently practicing.
Can you change the slide?
Sir, I have changed my slides.
Yeah.
She is currently practicing as VR surgeon in Dr. Agarwal's Eye Hospital, Hyderabad. Dr. Janani Srinivasan, she completed her MBBS from CMC College 2012. She pursued MS Ophthalmology from RIO Chennai and completed it in 2015. She pursued clinical VR fellowship from Shankara Nethralaya, and she has more than 15 publications in peer-reviewed journals. She is currently working as an associate consultant in VR department. She received Best Outgoing VR Fellow as well as Best Lady Fellow in Clinical Vitreoretina in 2021. She was awarded Best of IGO Award in 2021 for article titled Venom-Induced Macular Infarction. So these are our speakers and esteemed panelists. I also welcome Dr. Atul sir, who is the moderator for today. And I would request Dr. Mahesh sir to please continue with the talk.
Sure, thank you very much. Let me share my screen. My slides are visible, right?
Yes, sir.
Okay. Thanks to Dr. Atul and the team of ASG for inviting me to give this lecture. So Dr. Atul wanted me to speak on retinal detachment and all about retinal detachment. So disclaimer is that no one can know everything about anything. Least of all me about retinal detachment. Whatever little I know, let me see if I can talk about it. The scope of this lecture is about management of retinal detachment. It's not going to be a lecture about like pathogenesis of retinal detachment and what are the different types of detachment and things like that. So as all of you are essentially practicing VR specialists, so it's going to be about management of retinal detachment. And essentially I'll be talking about scleral buckling and vitrectomy. I know scleral buckling is a dying art, but it's a wonderful surgery as I will show you. And I will skip pneumoretinopexy. And there's been a lot of buzz about pneumoretinopexy thanks to Dr. Rajiv Muni, and who has made all of us experts. At least theoretically, we are yet to put it into practice, most of us. So let's start with scleral buckling. So the principle of scleral buckling is not to close the break, it's to relieve the vitreoretinal traction. In addition, you may consider closing the retinal breaks as well. So what are the indications for scleral buckling? retinal detachment with indentable breaks. That is like in the OPD, if you are able to indent the break, put the break on the indenter, then this patient is possible to be taken up for scleral buckling. But this is not always true, as I will show you a couple of examples. Even very posterior breaks, you can do scleral buckling with a little bit of maneuverability. And if there is detachment with PVR up to C1, you can get away with scleral buckling. The caveat is that the PVR fixed fold should not be close to the break. If it's close to the break, then you would not be able to oppose the sclera and the choroid to the break, because the fixed fold will keep the break open. So the PVR somewhere else away from the retinal break, it should be possible to close it with scleral buckling. And no vitreous hemorrhage or choroidal detachment. Vitreous hemorrhage not exactly is a contraindication in the sense like we are not able to identify the rest of the retina sufficiently enough to see if there are any other breaks. That's the reason vitreous hemorrhage is a contraindication. Otherwise, you can do eyes with the vitreous hemorrhage and retinal detachment. You can do a scleral buckling, but the area covered with the vitreous hemorrhage, if there are any breaks, you'll be missing them. Choroidal detachment, we used to manage eyes with retinal detachment, choroidal detachment routinely with scleral buckling, but then subsequently we did do a study in Shankaran earlier where we compared eyes with choroidal detachment and retinal detachment, comparative study of vitrectomy versus scleral buckling, and found the risk of recurrence and PVR to be higher in eyes managed with the scleral buckling. The inflammatory mediators which are in the vitreous cavity in an eye with choroidal detachment are effectively removed when we do the vitrectomy. So the risk of recurrence is lesser if we do a vitrectomy. So CD with RD is preferably managed with vitrectomy nowadays, though you can actually do it with scleral buckling. Actually, sometimes it's very easy because the CD sometimes will tamponade the retinal break. Sometimes you've got away with just doing a laser barrage around the retinal break, which the CD itself acts as a buckle. Other relative indications are retinal detachment in young patients because they have a formed vitreous and the PVD may not be there and it will be quite adherent. So the vitrectomy can be difficult. And these young patients go on to develop a cataract and many times they are myopes. So if we do a cataract surgery, we land up with anisometropia as well. So in younger patients, preferable to do buckle and easier vitrectomy tamponade with the scleral buckling because the formed vitreous actually tamponades the break when you push the sclera and the choroid towards the vitreous cavity. Presence of subretinal gliosis to me indicates the break is small. So that's why the RP cells have not come into the vitreous cavity. When the RP cells come into the vitreous cavity, then they give rise to periretinal PVR. But if there's a small break and there's RP proliferation under the retina, then that gives rise to subretinal gliosis. So in the presence of subretinal gliosis, it's actually easier to do a buckle rather than do a vitrectomy. And the RD associated with lattices, if there is no PVR, I would prefer doing a buckle because the lattices will have vitreous all around attached to it, and it may be difficult to dissect it with ease. So in those situations, once again, you can manage them with scleral buckling. So when there is a PVD, what happens? The vitreous space, the vitreous is still attached, and that's exactly where the horseshoe tear occurs, as it is shown here. And what the buckle does is relieve the vitreoretinal traction. Primarily, you're not trying to close the break, but relieve the vitreoretinal traction so that the flap goes back and closes the break. So the goal of scleral buckling surgery, or for that matter, any retinal detachment surgery, is to identify all the breaks, do retinopexy, relieve the traction, and SRF drainage is not an essential part of scleral buckling surgery. It may be done in select situations. So how do we identify all breaks? This was actually history. We used to do thorough indirect ophthalmoscopy examination with scleral depression and then do a detailed fundus drawing, and then we'll have a fundus drawing check. And in Europe, people used to do a gonioscopic slit tab examination. In fact, there used to be a gonioscope with a scleral indenter as well. So you can put a gonioscopic lens and then indent and see the periphery also on the slit lamp. All this to be done. But currently, I am sure like the practice of doing drawing has been given up. So people do optus images or examine on the table, and of course, like you do vitrectomy much more often than a scleral buckling. But I would still suggest doing a fundus drawing just to improve the indirect ophthalmoscopic skills. So moving on to, I'm skipping the conjunctival opening, tagging and all that. We move on to the crucial step of localization. What would you localize in a patient with retinal detachment when you do a scleral buckling surgery? If it is a HST, we would want to do a 3-point localization, the apex of the breaks and the 2 horns. So this would have to be marked out on the sclera. If it is a lattice degeneration, the posterior most and the lateral most is what you would have to mark out. So this is the posterior lateralmost. You put one mark here, and when we buckle it, the whole thing will come on the buckle. If it is a single point localization, preferably the posterior most part of the hole. If we localize, that should be adequate. So a localization mark, I usually prefer a cautery. So use a forceps, then indent it and immediately roll the eye. Look at that indent mark and make it permanent by putting a cautery mark. We can use diathermy as well, and there are diathermy probes which can be used in the indent and as well as put the mark at the same time. Dye is something which I don't prefer because in the wet surrounding of a scleral buckling surgery, the dye is likely to diffuse out and it may get vanished. So I usually use a cautery. So the key point is once we localize, immediately what we do is to put a cotton bud applicator on the localization mark, then roll the eye and depress and see inside. So that will give us an indication if the localization is up in the correct position and if the break is going to fall on the buckle. The indent caused by the bud, if the break is going to fall on that, then you know that like the buckle will also be in the appropriate place. The localization is the most crucial step as far as scleral buckling surgery is concerned. Of course, like all the breaks have to be identified. Once you identify all the breaks, localizing it on the sclera, localizing it correctly is very, very crucial for the scleral buckling surgery to succeed. So what do we localize? Because it's not as though a patient presents with just one HST and one lattice. It's usually a combination of everything like this. As you see here, the patient with the HST and two lattices. So you localize here. So the buckle will extend from here to here, isn't it? So you localize the posterior lateralmost part. So this is the lateralmost part where the buckle should start. And this is where the buckle should end. And how posterior it should be. So this is the posterior most extent. So these are the 3 points you localize. So here you don't sit around localizing the 3 points of the HST, but then from where to where the buckle should extend is where you localize. So in a bullous retinal detachment, all of us are familiar with the parallax error. Because the retina is lifted up, you tend to localize it much more posterior than anteriorly. So how do we correct this? So we start indenting from the ora. You can see start indenting from the fora and actually reattach the retina on the choroid and then drag it posteriorly. So that way you are likely to localize in the correct position rather than not starting at the ora. Starting at the ora, depressing it, and then making the retina flat over the depressor will make the localization mark correctly. And there are also indirect clues. So you will see a lattice which has left some pigmentation here, or in the choroid. So the HST is close to a lattice, and you will see the pigment in the choroid associated with the lattice. That will also give us a clue as to where the posterior part of it is. Next step is, of course, like you can drain to make the bullous retinal detachment flatter, and then go ahead with localization. So here you see the diathermy probe which has been used to drain the fluid, and then you can reattach the retina and then localize. So this is a modification of the DACE technique. I don't like the DACE technique, which the A stands for air injection. So once you inject air after you drain the fluid, what happens? It mucks up the view, and it may be multiple bubbles, and even if it's a single bubble, there is a minification of the image. So fundus visualization is not too great. So I drain, inject fluid. You don't want to drain it dry. You just want the bullosity to go down so that you are able to localize properly. So you drain somewhat, inject fluid, and then localize, and then go ahead with the surgery. So there's a modification which was designed by my colleague Dr. Divyans. So you take an old light pipe, a 20 gauge light pipe, and bend the tip, and you can use this to localize. So what happens is we are not too sure if it's the shaft which indent we are seeing or the tip indent we are seeing. So this can pretty much be circumvented by starting at the depression at the ora and taking posterior. But otherwise, using this illuminated indenter is also a very good technique of precise localization, because what you're seeing, the light is exactly where the tip of the instrument is. So you can use a light pipe, a 20 gauge light pipe, which is a bit more sturdier than a 23 gauge or a 25 gauge. If you want, we can bend the tip a little bit and use it as a localizer, as an indenter to localize precisely. This also identifies the breaks because you can see the illumination through the sclera and choroid. You can see the break pretty much well defined on the illumination. Next, the retinopexy, the most commonly preferred retinopexy is cryotherapy. We can use photocoagulation as well. So we used to have this diopexy probe, which is an 810 nanometer laser probe. it's shaped pretty much like a cryo tip itself, and transclerally you can deliver the laser energy. So you can pretty much use it like a cryoprobe, and you can see the laser spot inside and create a burn. But the caveat in diopexy is the retina has to be really close to the RPE so that like the burn is seen. Otherwise, you will be creating a burn on the choroid, which may not be very obvious. So that in the shadow retinal detachment, you can use diopexy. But of course, you can do LIO after reattaching the retina in the postoperative period. Earlier, we used to use diathermy. Diathermy gives the strongest adhesion. So actually, diathermy burns need not be confluent. It can be staggered. Actually, we used to put staggered burns in diathermy, but diathermy needs an implant, like a partial thickness dissection of the sclera, because diathermy tends to shrink the sclera, so the IOP can go up. So we need to create a scleral flap, and in the thinned out sclera, we used to do diathermy. That's why initially we used to use diathermy as a retinopexy. That's why implant surgery was what was being done earlier. Cryo, when we do cryo, what do? Use one row of application around, and the burns should be touching each other, because diathermy, as I mentioned, can be staggered, but laser and cryo, the burns should be touching each other to create a good barrage. And if it's possible, we should extend to the aura. So treat around and then extend to the aura on either side. And we should avoid treating a bare RP because it liberates the RP which comes into the vitreous cavity and increases the risk of a PVR formation. So why should we extend it to the aura? Because though we have buckled it, and if you have not taken it to the aura, there is a possibility that the fluid can leak in the anterior part of the break, can give rise to a retinal detachment. That's why it's better to take it to the aura if the breaks are closer to the aura. So similarly, we can create an illuminated cryoprobe to take a discarded light pipe and remove the handle, and then thread it along to the cryoprobe with a sleeve. So you can have an illuminated cryoprobe, because this is another concern we have, whether what we are seeing when you do the cryo is the shaft indentation or the tip indentation. So if it's a shaft indentation, you can have disastrous macular cryo burn. So to prevent that from happening, we can create an illuminated cryoprobe like this, and you can pretty much precisely see where the tip of the cryoprobe is and do a precise cryo as well. So next is, like, we finished the pexy, then what do we support and how do we support? So which part do we buckle is what we will be dealing with next. In the initial days, every lattice degeneration in the detached retina, every break is what we used to support with a buckle element, not an encircling element, with a buckle element. So this is how I would have done a buckle in this patient about 20 years back. But now I have modified it, like, so the lattices I'm just supporting them with an encircling band, and only the breaks I support them with a solid silicon. So even if there are atrophic breaks in the lattices, it's okay to support them with an encircling band, because there is still formed vitreous. Just pushing the lattice toward the formed vitreous closes these atrophic breaks, and the retina remains attached. You don't really have to buckle these lattices as well. So how do we select the buckle? So what is the size of the buckle which you want to put in a particular patient? So if it is close to the aura, you always buckle from the aura. And most important is this posterior measurement. So there should be at least 3 millimeters clearance posteriorly and 2 millimeters clearance on either side. So if it is, the break is about 5 millimeters from the aura, then at 3 millimeter clearance would be 8 millimeters. So use a 8 millimeter buckle or a 9 millimeter buckle, which is a 279. And on either side, there should be at least 2 millimeter clearance. So this will make sure there is no fish mouthing or there is no slippage of the buckle and there is no leakage of the fluid. If the break is away from the aura, then anteriorly as well, you use 3 millimeters. So posteriorly 3 millimeters, anteriorly 3 millimeters. This will give a good buckle effect, which will cover all aspects of the break, and risk of recurrence is much lesser in this situation. So if you had a sutured buckle, where do you place the suture? So it's the buckle plus 2 millimeters. So if it is like, so you had 2 millimeters, you place the sutures 1 millimeter anteriorly and 1 millimeter posteriorly to the buckle size you wanted to place. So if it is a 9 millimeter buckle, you place the sutures 11 millimeters apart. So if it is shorter than this, then what happens is the sutures come too close to the buckle, and the buckle effect is not too good because the sutures are not able to push the buckle inside. There should be sufficient sclera on either side to push the buckle inside. So it should be 2 millimeters. If it is too farther away, if it is more than 2 millimeters, what happens is the buckle can slip anterior-posteriorly within the sutures. So if it slips anteriorly, then the break may not be tamponaded properly. So the ideal measurement is 2 millimeters. Basics of sutures is like the suture should pass half thickness through the sclera, and always visualize the travel of the needle tip. It's kind of a bobbing motion we take, and you can see the needle traveling through into the sclera. And posteriorly, the sutures are broad and anteriorly narrow, and they should be close to each other. At least they should be close to each other. So because what we're doing is like from anterior-posterior, the globe expands. So the posterior bite should be broader as compared to the anterior bites. And the bite should be close to each other. And there should be at least, if you're buckling one quadrant, there should be at least two sutures. You can place more than two sutures, but to buckle one quadrant, one suture will not be adequate because the buckle will sag out in between the two sutures and a good buckle effect will not be there. So here you can see the needle is going in and you can see the track of the needle and you can see the tip of the needle. You see bobbing motion is what we do. And when we are likely to perforate is actually when you pull out the needle. So when we pull out the needle, it should be a circumferential motion, but instead we pull it up abruptly towards us. What happens? The hub can go posteriorly and rupture the sclera there. So when we pull out the needle, it should be in a circumferential motion rather than pulling it abruptly towards us. So here you can see the video. So this is actually I'm augmenting the buckle. So I'm slipping a piece through the pre-existing buckle to extend the buckle posteriorly. So I cannot leave it like this. So what will happen is this will sag out and the buckle will not work. So you can see the needle passing through posteriorly and then anteriorly you can see again. You can see the tip passing through and then the knot is taken. So this is another way of taking the sutures. Anteriorly, if there's no space, you can take a radial bite and then a circumferential bite. You can see the oblique here. So you can take the suture on either side of the oblique. Similarly, you can do this for eyes where the vertex vein comes. Of course, like we don't do such posterior buckles anymore. But if you were to do that, you can skip the vertex vein. You can take sutures on two bites on either side and take it as well. So here again, you can see it's going through the muscle incision, base of the muscle incision. So you can take a radial suture like this as well. So instead of always taking a circumferential suture where there is lack of space or scleral thinning, we can take the anterior bites to be radial as well. So here we see a radial buckle. So this is quite a posterior buckle. So here a circumferential suture will not be possible. So we go anterior-posteriorly. And you can once again see the oblique there. And you cannot come back, right? Like you cannot come from posterior anterior, it's very difficult. So you can place the suture once again, place this bite again anterior-posteriorly. Then what we do is we cut this X and the posterior two limbs we kind of tie together. So that way you can make a cross knot into a box knot. So this is how you can do a posteriorly placed radial buckle as well. So this way you don't have to come from posterior anterior. Both the bites can be anterior posterior. So this is a single HST posteriorly placed. You can manage it with the radial buckle. So, but more often I do a sutureless scleral buckling. So what is the basis of sutureless scleral buckling is if the area to be buckled is less than half a quadrant, that's about 1.5 clock hours, just a sutureless buckle will work. So what we do is to place two tunnels adjacent to the break and slip a piece of buckle here. So the key for the buckle, the sutureless buckle to work is the area to be buckled should be less than half a quadrant or 1.5 clock hours. So just slip one piece of buckle here and you don't have to tighten the encircling band too much, just about adequate is enough. So you can see there's a localization mark there and you place one tunnel adjacent to it. Actually, the localization is under the muscle here. And you can see that's a localization mark and you place another tunnel on the other side. So the area to be buckled is about 1.5 clock hours here. Then pass the encircling band through and slip the buckle in between the two tunnels. So as I mentioned, there's no need to tighten the encircling band too much, just about how you would tighten in any other cases, that is adequate enough. Because the band passing through between the two tunnels is sufficient to create a good buckle effect. You can do sutureless buckle in multiple quadrants as well. So if there are two HSTs, you can kind of create two more tunnels here. Either way, you would be placing the tunnels for the encircling band to pass by. So you can create two areas of buckle as well. With the sutureless buckle, you can do as well. Earlier, this is how we used to buckle a patient with a HST under lattice. But as I mentioned earlier, I do a sutureless buckle for this HST and support the lattice with the encircling band. So lattices with multiple breaks and multiple quadrants, yes, you can do a vitrectomy, but you can get away with the buckle itself. So where there are broader areas of lattices which need to be supported, I use a 42 band. So 42 band is double the width of the crescent blade. So you can use the crescent blade itself to create the 42 band tunnel. And only problem is in adjusting the tightness of the 42 band is a bit of an issue. So here I'm using a claw hitch knot. And in select situations where there are multiple lattices and then like there is a HST as well, you can modify the existing buckle to fit under the 42 band. So this also can be done because the groove in the existing silicon buckle is about 2.5 millimeters, which is designed for the 240 band. We can dissect out the groove to be a bit broader and then put it under the 42 band as well. So this is a modification which we can do. If you have multiple lattices and one HST and you want to support all the lattices and the lattices are in the detached retina. So here once again I'm doing a sutureless buckle, sutureless 42 band with a augmented solid silicon piece here. So this is a technique which was described by Skipens way back. It's an intrascleral buckle. There's nothing great about it except that it looks very elegant and you won't even see the buckle outside. So here we create a tunnel. It's not only the phacosurgeons who can make a tunnel, so we can as well. So anteriorly and posteriorly make the tunnel. So the key is like you don't make the radial cuts. So you just make a pocket, scleral pocket, and into which you put the buckle and then take one suture. So one localized quadrant where you don't need an encircling band, you can do this buckle as well. So in the like for the sake of history, here I'm showing an implant. So this is how we used to do. Create a scleral pocket, as I mentioned. So this radial cut is not there when you do a scleral pocket, but in an implant, you make a radial cut as well. With an implant, it's easier to take the sutures. The risk of perforation is very less because the scleral flap is there. You can move the flap this way, that way, see the tip, and then take the bites quite nicely. So that's how we used to do the implant earlier. And another modification, what I do is the visco buckle. So Bell Race has shown a particular cannula which you can thread from anteriorly and go to the break through the suprachoroidal space and like inject visco. But you can do it with our existing equipment itself. So this is a localization mark. I made a sclerotomy away from it. So sufficient enough for this visco cannula tip to go inside that. So inject a little visco, push the choroid away, and then inject visco exactly into the area of the under the break, so pushing the choroid forward. So you can see the buckle effect here. You can see this. So when would I use this? If it is a posterior break where you would not want to put such a posterior buckle, and just a single break where you want a temporary buckle effect, you can use a viscoelastic buckle as well. So the viscoelastic which are thicker or where the more viscous tend to take longer to absorb. So by the time they absorb, the choroidal atrophy has taken place, the choroidal adhesion has taken place, and the break is sealed. So subretinal fluid drainage, as I mentioned, is not an essential step. When would I do subretinal fluid drainage? When it's a bullous retinal detachment, patient has pre-existing glaucoma, long-standing retinal detachment where the fluid may take longer to absorb, and inferior RD with HST, because like you want the retina, the break closed on the table, you don't want it to be lifted up, and it may result in a failure. So non-drainage, if it's lattice associated, then you can get away without drainage. So though you will see the lattice lifted up on the buckle, it will still close, because once we push the lattice or the retina towards the vitreous, then the vitreous kind of tamponade the lattice excuse me, and the retina will attach. Young patient, you can get away with non-drainage because the RP pump is quite active. Superior retinal detachment, you can get away without drainage because you can use air as a tamponade. And when there is limited area of a drainage, you may be forced not to drain as well. Where do we drain? Area of maximum fluid, preferably on either side of the muscles, preferably the horizontal recti, because these are the avascular areas and the risk of subretinal hemorrhage is lesser. And preferably posterior, because anteriorly what happens, there is shallow detachment, and once the retina reattaches, we may not be able to achieve complete drainage. I'll show you some examples. So it's preferable not to drain close to the break. What happens if you drain close to the break, then the liquid vitreous will come through the break and come out through the sclerotomy, and the retinal detachment will remain the same, but the eye will start collapsing. So when we see undue amount of clear fluid coming out, and the eye becoming soft, then we should stop the drainage and see inside. If the detachment is the same, then that means that we have been draining liquid vitreous, and we need to drain away from the existing break. And if we are draining liquid vitreous, then better to inject air so that the break is tamponaded and further liquid vitreous doesn't come through the break. So when we do a choroidotomy and drain, preferable to drain between the bridging choroidal vessels to decrease the risk of subretinal hemorrhage. We can see these vessels under magnification of the microscope and perforate between the two. And as I mentioned, better to drain along the upper bottom of the lower bottom of the horizontal recti, and visualize under the microscope and perforate between the vessels. So, but this is a technique which I use. I use a 26 gauge needle. You can go tangentially, and as you can see, the needle tip or the bevel is kept in the track. So what happens? The needle is not completely inside; it's withdrawn, and just the bevel is in the track, so that this keeps the track open and doesn't just the subretinal fluid drainage can be completed by keeping the track open. So if you go inside and come out, there's a possibility that sclera can contract and premature cessation of fluid can also be there. If there's a shallow retinal detachment, particularly in eyes with lattice degeneration and localized detachment, which is shallow, it's difficult to drain with a needle drainage technique. So one is, of course, as I mentioned, you can get away with a non-drainage. Or if there are limited choice of drainage site like a vertex vein close to the break or risk of retinal injury, we can either do a non-drainage or do a laser choroidotomy. So here we prolapse the macula of the choroid, then use laser. Instead of using a needle which has to go inside and come out, the laser actually does a nice choroidotomy and cauterizes the choroidal vessels. So there is no risk of bleeding. And again, if in case there is a laser burn to the retina, that's okay, because the laser burn will not happen because there is no RP there as well. So this is a safe way of draining if there is a very shallow area of retinal detachment. And sometimes we come across patients with a shifting fluid in a retinal detachment. So sitting, you will see bullous inferior detachment. When the patient is lying down, you'll see more fluid in the posterior pole. In that situation, I would use a chandelier-assisted needle drainage. So here you can see the needle in the subretinal space. So you can see the chandelier here. Again, I use a 26 gauge half-inch needle. You can depress and see the needle indentation and enter into the subretinal space. You can see the bevel is facing the RPE. That's something which is important. The bevel should face the RPE so that the retina doesn't get sucked in. And you can tent up the retina a little bit and drain the fluid like this. So in a shifting fluid, you can use needle drainage technique. The advantage is you can go as posterior as possible with this needle drainage technique, which is not possible with the choroidotomy technique. So if there is sudden cessation of fluid, that means like either there is a retina RP opposition. So slowing of stream and pigment exit indicates that the retina has gone back to its place, and further pressure on the eye can cause retinal incarceration, or it could be an occluded track. So what we should do is to support the drainage site and then see inside to see if we have not created retinal incarceration before we proceed further. If there's sudden cessation of fluid, we should not keep pressing on the eye further to that will make things worse in the sense that there can be a further retinal incarceration. So if there is an occluded site, we open the site. And if there is the area where we have drained is reattached and there is no further point in draining here, create another sclerotomy posteriorly and a choroidotomy posteriorly. And in case we have incarcerate the retina. If it is a small incarceration, we can cryo and support with the buckle. If it is a large incarceration and the folds are going towards the posterior fold, the peripapillary area or to the macula, this is not going to get better with anything. We may have to do a vitrectomy and then do a retinectomy around this to relax this retina and reattach the retina. So how do we avoid incarceration? If there are areas of subretinal gliosis, you can drain under this so that the subretinal gliosis or the fixed fold will keep the retina tented up so that it doesn't incarcerate in the site of the choroidal artery. So how do we avoid subretinal hemorrhage? As I mentioned, drain close to the horizontal meridian, away from vertex veins, avoid choroidal vessels and use laser or diathermy, avoid hypotony, sustained pressure on the globe and sudden release of pressure when we are draining the fluid, and once the fluid is stopped coming is when the subretinal hemorrhage can occur. So you can use an infusion assisted drainage as well. I'll show you the technique here. So you can put a 25 gauge infusion, and the key is to drain in the same quadrant, because when we roll the eye, so if it's in the inferotemporal quadrant, this infusion need not be inferotemporal quadrant. Wherever we want to drain in the same quadrant, we put the infusion, then the roll the eye so that the infusion canal doesn't kink and hit the retina or the lens. So in the same quadrant where we want to drain, put the infusion cannula and drain posteriorly. So buckle is possible anywhere, and this is a patient who is a 35-year-old HIV positive lady, and she had a healed retinitis, chororetinitis, and one eye she had no light perception, and the only eye she had light perception indirect projection, and the choroidal scarring post CMV retinitis was involving half the retina, and the disc and macula were also within the scar, and the rest of the retina was detached. So this is how it was. So the disc was somewhere here. So there is no way we can get away with the vitrectomy in this patient, because like we can't do a retinectomy which will involve the disc and the macula, and this is the area which is detached. So this is a very difficult situation. So what I did was to manage with the buckle. So it was a very posterior buckle. The break was around 2 disc diameters superior to the optic nerve head. So here once again I am doing a needle sutureless buckle, a drainage. And because I wanted a higher intent, though I made 2 tunnels, I created a suture also. So you can create a posterior sutured buckle with a bit of difficulty, because that's the only thing which would have worked in this patient. And what you see here is the retina reattached, and she got back about like 3/60, 4/60 vision. Yet another patient, one eye had been lost after multiple vitrectomies. This is the only retina which was remaining. Elsewhere, the patient had surgery. And this eye also, the patient had about 3 surgeries before he came to me. And high myope. So he had this macular detachment. There was this epiretinal membrane or posterior hyaloid. Did vitrectomy, used Densiron, and it reattached for some time. And then subsequently it detached again. I did subretinal fluid and endo drainage. Again, the patient had a recurrence. So one of the problem was there was a break in this area of choroidal atrophy. So whatever I do, this area of choroidal atrophy could not be reattached. The patient had a very deep staphloma, and ultimately we put a macular buckle. So not exactly on the macula, we put it in this area of the choroidal atrophy, and subsequently patient reattached. And sometimes I do this scleral imbrication technique when it's a very high myope and there is a big posterior staphloma, and you don't want to do a vitrectomy, and you can't do a macular buckle. You can actually shorten the temporal sclera. So this scleral imbrication is taken across the lateral rectus. So half a quadrant in the inferotemporal quadrant, half a quadrant in the supertemporal quadrant. Here, instead of pushing the sclera in, you are shortening the sclera, and this is the effect. The patient had a macular hole and a recurrent detachment, and you can see the posterior staphloma has flattened post scleral imbrication, and the macular hole is closed as well. Now, coming on to vitrectomy techniques and retinal detachment, all of you are very, very familiar with the vitrectomy technique. So I'll be touching on some points what I would do. So this patient has a mobile retina and no PVD, and a young patient, and possibly dialysis there. So induction of PVD in a mobile retina and retinal detachment we do vitrectomy is something which can be very, very daunting. As you can see here, once we start sucking the vitreous, the whole retina moves. So here I have used triamcinolone and creating one hole in the posterior hyaloid. So once we create this hole, then we start working on it and induce the posterior vitreous detachment. So here, once we have cleared the posterior pole, we can put a perfluorocarbon liquid to make the posterior retina taut and then peel the hyaloid anteriorly as much as possible and then complete the vitrectomy. So in a patient like this, I would have preferred to do a buckle, but then the visualization was not there because the patient had a cataract as well. So this is another patient with a partial retinal detachment, and once again, no PVD. So this is a technique where you can use PFCL through a hole in the posterior hyaloid. Dr. Vishal Agarwal had initially described this technique. I think he calls it a big bubble technique or something like that. You create one hole in the posterior hyaloid and start injecting viscoelastic through that. But here it really didn't work that way. But some amount of the PFCL went posterior to that. But not all the time it works. Like you can inject this through the hole in the posterior hyaloid. Sometimes the hyaloid will lift up, but here it didn't really happen. But then it kept the temporal retina attached, and using a forceps, we are inducing the vitreous detachment. You can see the forceps is being used to induce the vitreous detachment. Otherwise, like if you persist with the vitreous cutter, what can happen is we can catch the retina in multiple places because the vitreous is attached to it and create multiple breaks. And once we create a break with the vitreous attached to it, then it becomes very difficult to manage because these are the breaks with the vitreous attached to it, which will recur and have PVR as well. Pathological myopia, I would stain and restain because there are multiple layers of vitreous. So what looks like an obvious hyaloid separation is not exactly the hyaloid separation. You can see the posterior cortex, which is still attached, which is stained by the triamcinolone. I would use triamcinolone once again and then peel the ILM as well, because the ILM also highlights the areas of vitreous which is attached. And once you peel the ILM, you know that for sure that we have peeled the posterior hyaloid from the posterior pole. And you can see that I have used triamcinolone once again to stain the peripheral hyaloid as well. So often the question comes when we would use a belt buckle along with a vitrectomy or a scleral buckling. So there are multiple studies which have said that you can use buckle, which increase the risk of, which increase the chance of retinal reattachment. There are studies to say that no, there is no need to do belt buckle or scleral buckling, just do vitrectomy. The chance of success are the same. But when I finish a surgery and come home, I want to sleep peacefully, not wonder about whether I should have done that extra step. So I do as much as possible on a given day, on a given patient, to make sure that I have done my best. So if the patient recurs after that, yes, it must be because of the disease, not because I skipped on something. So these are some guidelines which I have placed for myself as to when I would do a buckle. So here there is a patient with the HST here and a lattice in an attached retina, partial retinal detachment. Here I would not place an encyclic band, plus or minus. If you want to support this thinking that this vitreous is going to subsequently detach in the future, then you can consider an encyclic band. Here encyclic band is plus minus. I would not place an encyclic band. But if the lattice is in a detached retina, and if there is hyaloid separation anterior to the lattice, so from the vitreous base to the anterior part of the lattice, if the hyaloid is separated, then we are able to cut the vitreous around it. Then there is no need for an encyclic band. So you can manage it with just a vitrectomy. And the PVD is absent anteriorly. What can happen is this vitreous can contract in the postoperative period and can cause a recurrence of the retinal detachment or a retinal break there. So in that situation, I would just put an encyclic band there. Here you can see during surgery, we find that the vitreous base has shifted posteriorly. And you can see the retina getting contracted. I'm not able to peel the vitreous anterior to that. So the vitreous base has migrated posteriorly and it's adherent and contracted. In this situation, I am scared to leave it alone just with a vitrectomy. Whatever machine we use, we may still not be able to remove the vitreous sufficiently. We will be able to debulk the vitreous, but that vitreous in the periphery, that broad band, can contract. So here I have put a 42 band as an additional safety in this patient. So inferior HST, once again, if the hyaloid is separated anteriorly, we are able to isolate this HST from the anterior hyaloid, then there is no need to put an encyclic band. So you just have to do the laser. belt buckle is plus minus in this situation. So here you can see one example of that. You can see multiple HSTs, but the vitreous anterior is separated, or we are able to separate it sufficiently. You can see we are removing the anterior flap of the HST, and here you can see it's an operculated break. So the anterior vitreous traction is sufficiently removed. You can see there is no vitreous about 1 disc diameter or 2 disc diameters anterior to the HST. We are able to remove the vitreous. Then we can get away without doing a belt buckle or a buckle in this situation. So inferior HST with adherent anterior PVD, it's, as you can see, it's an inferior HST, horseshoe tear, and this anterior vitreous is not separated. Then I would sometimes support with the buckle itself. Here you see one example. There is a patient whom I managed recently, patient an RD with the seeding. So here I am using a 6 mm cannula. So I've just entered just up to the tip of the MVR, then injected through the other side fluid to drain the choroidal detachment, then fix the 6 mm cannula. Then we going ahead with the vitrectomy. So after the vitrectomy, I tried looking for the break, but I just couldn't see where the break was. This patient was one-eyed and had history of uveitis. So I'm depressing and looking for the break, but I'm just not able to. And inferiorly, there is this thick band of scarring at the vitreous base. So despite everything, I'm unable to see where the break is. And I would like to see the peripheral break at the original break rather than reattach the retina by doing a drainage retinotomy. So despite multiple attempts, I am unable to see the break. So I put a bubble of perfluorocarbon to see if the Scleral will help me identify where the break is, but that also didn't help me identify the break. So did the peripheral vitrectomy. So decided to remove the PFCL and inject BBG in the subretinal space. You can inject BBG transretinally, but I prefer to use the Scleral technique. So this is once again a 26 gauge needle loaded to the diluted BBG, so which was transclerally injected into subretinal space, and then put a bubble of perfluorocarbon and rolled it. And you can see the break is somewhere inferior. You can see the dye coming into the vitreous cavity through the break, helping me identify the break. Actually, it was a very large break. Once the dye came out through the break, I was able to identify the break. And this is a break which posterior part of the traction can be relieved, but anterior is not possible to relieve because that thick band of vitreous, contracted vitreous. Yes, I can do a very large retinectomy there, but I prefer not to do that because patient has uveitis as well and is a one-eye patient. So decided to do a buckle in this situation. So close the sclerotomies. I fill the eye with the oil as well. Placing a buckle post-vitrectomy can be a bit difficult, but I usually close all the sclerotomies, at least with temporary knots before I do this. And something solid should be there, either a perfluorocarbon or silicon oil is in the vitreous cavity. It forms the globe quite well. And decided to do a sutureless buckle here. So the break was somewhere around 6 o'clock, a bit posterior. So put a 279 buckle there. So this is one of the classic indications where I would do a vitrectomy plus scleral buckling. So the vitreous contraction inside cannot be relieved sufficiently or would need an extensive retinectomy. I can do this. So when we do a vitrectomy, we need to remove the preretinal membranes first. And sometimes it can be closed funnel like this. And right over the disc will be that little tissue which would have to be removed. So here we need to be careful about what we grab. So we need to identify the tip and then grab it and then open it up. And usually forceps is what I would use because sometimes you can grab the retina and create a posterior break. So we need to be careful when you open it up. And then once that posterior fold is opened up, then graded injection of perfluorocarbon. You put a little bit of perfluorocarbon, then induce the PVD. And once sufficiently the PVD is separated, then inject a little bit more perfluorocarbon and then keep doing that. This patient had traumatic iridodialysis as well. So until this time, I was able to do the surgery without the iridodialysis bothering me. But then I resutured the iridodialysis because I was going to do the vitreous base excision. So here I am depressing with the muzzle hook here, and vitreous base excision can be done through the microscope or through the wide-angle viewing system as well. So I usually prefer to do through the microscope rather than the wide angle viewing system, because I can depress myself rather than the assistant using the depression. So we reattach the retina with perfluorocarbon in the laser photocoagulation. So pre-retinal membranes, how do I identify? Sometimes I use directly the forceps to go in the apex of that, or the center point of that fixed fold, grab the PVR and then peel it. Usual peeling is from posterior to anterior. Sometimes it can be circumferential as well. And this is once again showing the vitreous base excision. So here I'm using the cotton bud. So you can use either use the cotton bud, the cotton tip applicator, or the muzzle loop. Cotton tip applicator, the advantages, it doesn't slip when we depress on the sclera. But the disadvantages, you may not be able to use the cotton tip applicator on the nasal quadrants when you have not opened the conjunctiva. In contrast, we can use the muzzle loop on the nasal side as well. The disadvantage of the muzzle loop is it can slip on the sclera. That's the only problem. So I use either of the cotton tip applicator or the muzzle hook to depress and do the vitreous base excision. See here, other thing what you saw was the PVR at the edge of the break. So which is what we cauterize here. So at the edge of the break, we may not be able to remove the PVR completely. So what we do is to cauterize and destroy that PVR which is rolling up the edge of the break. So that like this doesn't, so you can see the cauterized edges and then removing of that edge of the contracted retina around the break, so that this doesn't result in a recurrence of the detachment. So sometimes we can do PVR dissection under oil if there is a limited PVR and there's a recurrence. So the first step is to remove the fluid which is collected in the posterior pole. The oil is floating up and there is fluid posteriorly. Remove that. So either we put a silicone oil infusion and inject the oil and remove the fluid and then go ahead with the dissection. Otherwise, what happens is the silicone and fluid interface will not allow us to see properly. So remove that fluid, fill that cavity with oil, and then go ahead and remove the PVR as well. So, and not all the times I have a silicone oil infusion. Earlier, I used to put silicone oil infusion. The problem is, as we all know, the silicone oil infusion tends to make the cannula very slippery, can slip out, and it can become, the field can become quite messy. So I put the infusion cannula, but I don't turn on the fluid, and just the 2 sclerotomies, making sure that there is no oil leaking out of the eye. I use just press on the eye with your finger, and that's sufficient enough for removing the fluid which is collected posteriorly, and then go ahead and do the surgery and then inject oil through one of the active sclerotomies itself. The infusion cannula is there in case like we want to convert from doing surgery under oil to removing the oil and then doing surgery under fluid. So that is why I placed the infusion cannula. But most often, just with these 2 sclerotomies, we may be able to do the surgery. So if the retina is still stiff after membrane peeling, that is after removing all the pre-retinal membranes, then there is a possibility that that can be a subretinal gliosis. So here you can see all the pre-retinal membranes are identified using triamcinolone remove. So here I've made a retinotomy, one retinotomy rather, and then removing the subretinal gliosis through that. And the light pipe acts as the fulcrum or the pulley on which the subretinal gliotic membranes are pulled out. So this way what happens is, so exactly keeping it there doesn't allow the retinotomy site to extend. Otherwise, when you pull it, the retinotomy site will be torn with the SRG band. So we keep it here and then pull it like this so that the subretinal gliotic band comes through the break, doesn't extend the break. So very often I don't do a retinectomy in the periphery, fold the retina to remove subretinal gliotic band. A correctly placed retinotomy will allow us to remove almost all the subretinal bands without needing for an extensive retinectomy. So where do you place the retinotomy for removing the subretinal band? It should be the same meridian as the sclerotomy. So active hand, if the right hand, so it should be in the meridian of the active sclerotomy. And the retinotomy is not too anterior, in which case the forceps will not be able to elevate the retina. Should not be too posterior, in which once again, like you will not be able to access too posteriorly. So somewhere in the equatorial region is where we place the retinotomy, and then take the forceps inside and transilluminate through the retina to see the forceps and hug the retina. So if you go posterior, then you may be touching the choroid. So you just hug the undersurface of the retina, go grab the membrane, and once you tug and see how the retina is behaving, then bring it out. And once you bring it out, use the forceps, use the light pipe as a fulcrum on which the subretinal band is removed. And despite all that, we may still have to do relaxing retinectomy. This is one patient which is referred to me. You can see a break in the posterior pole just next to the disc. The posterior hyaloid was still intact. So we removed the posterior hyaloid. And you can see that break just next to the on the papillomacular bundle lifting up, and the patient had an inferior dialysis as well. And we peel the vitreous as much as we can and support the posterior pole with the perfluorocarbon liquid. And as I keep peeling the vitreous, you can see that the retina is contracted at the edge of the break. So you can see the contraction, and that is not going to attach. And you can see as I do the cautery, the retina is shrinking. That's exactly where the vitreous attachment stops. So anterior to that, the hyaloid is still adherent, and there is no way we can relax that. So the border as to where the vitreous is attached to the retina and the vitreous is not being peeled anteriorly is exactly where we start doing the retinectomy. And once we decide to do the retinectomy, it should be a bit liberal. But as I mentioned, if the retinectomy is in the area of attached vitreous, then what will happen is the edge will curl up and the patient will recur right on the table itself. So the retinectomy should be posterior to the vitreous attachment, but it should not be so posterior. Like we should try to peel the vitreous as much anteriorly as possible, and where it stops is where we should cauterize into the retinectomy. So what are the precautions when we do a relaxing retinectomy? Stabilize the posterior pole with peripheral PFCL. And this is a patient who has had a bad multiple breaks inferiorly and a posterior PVR and very thin atrophic retina. So earlier we used to use the spatula to identify the membrane, but most often I use the needle to identify the edge of the membrane to lift it up and then use the forceps. And of course, you can do a bimanual surgery with a chandelier and hold it with one hand and tap the retina with the other hand to very atraumatically separate the membrane. Another technique what I sometimes follow is to put a chandelier, use two forceps and very densely other membranes, grab the membrane and tear them. So you can tear the membranes apart using two forceps. That's also something which you can do. But of course, you should make sure that you're grabbing only the membrane and tear them tangentially, not damaging the retina. So here there is an area of very dense adhesion of the vitreous where we are unable to peel a localized pocket. So a posterior retinectomy is being done for that area of localized pocket. I think patient probably had an endophthalmitis with very bad contraction of the retina. And all the breaks are being made into a continuous break. And this is one problem which can happen. If you don't cauterize properly, this patient, despite cautery, you can see a coronal bleed. So that blood has gone into the subretinal space. That is something which can happen when we do an extensive retinectomy. So we should make sure that all the edges of the retinectomy are cauterized very well, and we cut anterior to the cautery so that it doesn't bleed into the subretinal space. And of course, the anterior flap has to be excised, otherwise it can contract, get adherent to the ciliary body and can cause hypotonia as well. And this is one patient where there is an anterior PVR, which we are dissecting. The patient is a phakic patient, but young patient. So if the patient is young, the lens is not too thick. So you can sufficiently do a good dissection anteriorly without touching the lens. So you can see here what I'm using is the muzzle hook to depress, and you can dissect up to the ora itself very carefully if we know what we are doing. So you can not necessary to remove the lens in all the patients if you were to do an anterior base dissection. So here is a patient who has had a surgery and a recurrence with a very severe vitreous base proliferation. So these are eyes which will usually end up in hypotony. You can see the thickened vitreous base with a mass which is there, a very thick tissue. So this is so thick that we cannot cut it with the vitreous cutter itself. So we have dissected and did the posterior retinectomy as well. And this tissue has to be removed through the limbus because there's no way we can cut it with anything. So very severe anterior hyaloid proliferation. You can see the retinectomy posterior lens reattached. So what is the retinopexy we do in vitrectomy? yes, laser is the preferred one and less release of RP and less PVR risk. But there are situations where the break is so anterior, patient is phakic and the laser probe will not reach, in which case you can probably do the anterior part of the treatment with the cryo and posteriorly you can treat it with laser. And whether I would do 360-degree laser, yes, earlier I used to do 360-degree laser in almost all the patients, but now I don't do 360-degree laser, treat only the lesions. And the studies have shown that it's the 360-degree laser versus treating only the causative lesion result in the same anatomical success. We need to be cautious about doing 360-degree laser plus belt buckle in the patient with high myopia. What happens is, in my opinion, it causes ciliary body hypoperfusion, and this results in hypotonia and antihylar proliferation. So when do I use gas and when do I use oil? Gas, no PVR, good traction relief. Usually not in cases with relaxing retinectomy, I would prefer to use oil. And when there's a need for longer tamponade, I use oil. And the patient is able to maintain position, yes, gas, otherwise oil. And preferably superior and fewer breaks, then I prefer to use gas. Multiple breaks, inferior breaks, heavy oil is what I prefer, but though heavy oil is something which you don't get. I use tamponade, PFCL as the tamponade in some situations. Functional other eye, yes, you can use gas, but if it's a one eye patient, earlier visual rehabilitation oil is what is required. Primary surgery, I would prefer, that is the first surgery I'm doing, then I would prefer to use gas rather than revision surgeries, I prefer to use oil. Short-term PFCL tamponade is something which I do use. Probably about a month and a half, I leave PFCL, and if everything is fine, I remove the PFCL and leave it with BSS. Otherwise, I replace it with silicone oil at the end of a month and a half. When do I do that? And inferior large RR in patients who are doubtful to maintain positions or pediatric patients, I prefer to use short-term PFCL tamponade. And if it's a contracted retina where I am unable to open up the retina completely or flatten the retina completely despite removing all the membranes, particularly in post-traumatic patients, I leave the PFCL, I don't do retinopexy, ask the patient to maintain a supine position, then it kind of relaxes the retina, and subsequently a week or two later, I go back and then redetach the retina, remove some more membranes if they have formed again, then flatten the retina and use silicone oil. So to summarize, if there's no PVD, less chance of PVR, it's easier to manage with scleral buckling. And meticulous dissection and vitreous removal is the key to success in vitrectomy for retinal detachment, and traction relief is with PVR removal, added buckle in select situations, followed by subretinal gliosis removal if in case the retina is still stiff. And then if it's still stiff, then you resort to a relaxing retinectomy. Thank you very much for your kind attention. I am sure there are many more things to be talked about or included, but I have already exceeded my time by about 15 minutes. I hope you found it useful. Thank you very much.
Thank you so much,
Great
sir,
lecture,
for a
sir.
wonderful
Thank you.
presentation, sir.
Atul is too greedy, I guess. He has finished the entire VR in 1 hour. So each topic, each heading is a topic by itself for discussion. But entire VR and buckle, Atul wants to finish in 1 hour.
I want to gather more and more information from sir. That's why.
Then you have to give sir each heading a topic, as a topic and a talk. Then you'll have a lot of things to gather from sir, even the minute points. And I learned the buckle surgery from sir. Sir is a buckle master, and in SN in beginning days we used to do. I'm sure sir would have done more than 7 or 8 buckles or even 10 buckles in a day. When I was a consultant, I was doing around 7-8 buckles in a day. So buckle surgery is one of the best surgeries, I would say. If done, because the advantage of the buckle surgery, you know the result of the surgery within 24 to 48 hours. So if the retina is attached in 24 to 48 hours, you need not worry about surprises. In a vitrectomy, after a month, you'll have a lot of surprises sometimes. Whereas in a buckle, 24 to 48 hours, the retina is attached, you know for sure 99% nothing will happen at a later date. So that's the beauty of buckle surgery, and I learned that art from sir, and real thanks to sir for making me a good buckle surgeon and also VR surgeon.
Kasi sir, we can start the discussion.
Yeah.
Yeah.
If there is not much of questions, I don't think anything there is in the question. One person has asked about how do you measure how many millimeter is the break and distance from ora. That I told a caliper, and always measure from the muscle ring. So muscle ring is approximately the ora serrata. And from the muscle ring, use a caliper to measure the from the localization spot. That's what I said about that. And then what is everyone's choice of segmental buccal? If sponges, which one? Sponges, I personally haven't done much sponges. I usually prefer a buccal in the vitrectomy current era. If it's a posterior break which cannot be localized, I usually go for a vitrectomy rather than a sponge. I don't know, sir.
I have hardly used sponge. I have something against a sponge because sponges used to get infected earlier days. Because you stretch the sponge, what happens? The cavity inside the sponge tends to harbor organisms. I have removed sponges as well. So, listen again, like we had a preference not to use sponges. So I have hardly used sponges. So, and like you can pretty much get everything what you achieve with the sponge with the solid silicone as well if you know how to go about it.
I also come from the same school. The only thing with the sponge is with the buccal height, what you see on table, the next day the height will be much more because the sponge imbibes more water, and you should not try to give a much buccal height on the table because sponges usually for horseshoe tails, fish mouthing, posterior breaks, they use sponges. And invariably on table, you might try to have a high buccal height. But the next day, because the sponge swells up, the buccal height will be much more. So very rarely I have also used sponge, but most of the time it's buccal. And buccal usually 276, 279 is the preferred silicone tiles which I use most of the time. And regarding the sir said, the augmentation of the buccal, you can always shave the anterior part of the buccal and insert as sir showed for the 42 band. That you can do for augmentation also. On the table, you found the break is not well supported posteriorly. You can shave the anterior part of the tire and then insert under the buccal and then take a suture on it. And the other part which sir was mentioning, localization. Localization always, the localization is the most important step of the buccal. Any complication of the buccal you can get away if you had a proper localization. And localization, once again, we reconfirm. Once you have localized with the forceps or the light pipe, whatever modification sir said, while you do a cryo also, again, because the suture is pulling the muscles, while you do the cryo, again, you can reconfirm that your localization spot is correct. So a double reconfirmation during the cryo. And as sir said, first try to, when you use the cryo, to retinopexy or the cryo, the break, always start from anterior to posterior. Say if you have done the posterior break and if the false localization, the cryo reaction might be tend to be more posterior. So when you use a cryo, especially in a bullous RD, start the cryo from anterior. Even if it's posterior, the cryo reaction maximum comes to the posterior part of the break. So always start from the anterior and go posterior. That's what I was thinking about the localization. And
Dr. Janani, any comments on Sir's presentation and any thoughts?
Yes, sir. Sir, I wanted to have a few questions and mainly vitrectomy, sir. So, how to prevent ERM post vitrectomy when we sure that it feels like on table we have removed the posterior highlight, at least from the posterior port. Even simple cases, single break, we have nicely done vitrectomy. Retina is well attached. Still, at glass appointment, patient is like 660 with oil with ERM, and most of the cases I feel. So like whether some steps has to be modified, whether it could be related to like a 360-degree laser or what needs to be modified. Sir?
As I mentioned, Dr. Jani, that I stopped doing 360-degree laser. In very select situations, I do 360-degree laser. The more inflammation, the more of the chance of an ERM formation. Now, yes, if it is a macula attached to RD, then I prefer not to peel the ILM, but otherwise if the macula is detached, then I tend to peel the ILM as well. So peeling the ILM seems to decrease the risk of an ERM formation. But again, the jury is out there, whether you want to peel the ILM in every patient with regular RD. But of late, yes, I have been peeling this ILM. In high myopic patients, as I mentioned, I would stain and restain with triamcinolone, then use BBG, and then remove the posterior highlight as well as the ILM. In myopic patients, yes, I would have an increased tendency to peel the ILM, which decreases the risk of an ERM formation. But yes, it can still happen, but the way I avoid it is by doing an ILM peeling of late nowadays.
If you see ERM, the reason for ERM is inflammation. So what are the reasons for inflammation in vitrectomy? If you just go through that, each step, then you can avoid it. One, if there is already a PVR, there is already means there is a lot of PVR, means there is an ERM. So when there is a lot of PVR, better to peel the ILM as well, so that there is no nidus for the ERM to form. And excessive laser also can be avoided, or a cryo can be avoided. Third thing is the duration of surgery. If the duration of surgery is more, then yes, that itself can induce an ERM. And I remember when I was working as a training consultant under Sir, sometimes we do inject at the end of the surgery 0.01 ml of Decadron. So inside the eye, intravitreally, as we given in an endophthalmitis, we can inject 0.01 ml of Decadron to reduce the inflammation. Or sometimes, most of the time, we use IVT. I don't use IVTA for inducing PVD. So that IVTA crystals, residual crystals, which is there in the eye, that itself can reduce the incidence of the ER.
Yes.
This is a perception. We injected Decadron. I'm not too sure if it works or not.
But I do it. I still follow. I keep following, sir. I inject Decadron 0.01 ml at the end of the surgery.
Dr. Aarifa, any comments?
Yeah. Thank you, Dr. Ganesh. First of all, Shanmugam sir, thank you for such an excellent talk. It's always a pleasure and honor listening to you, basically. Actually, I just wanted to ask a question regarding macular buckle, especially in cases of RD with macular hole, where we do vitrectomy with ILM peeling in high myopes. When do you decide that macular buckle would be a better option in such cases, and it might not settle alone with vitrectomy and ILM peeling?
Once again, the jury is out on this as well. Okay, it depends on whom you speak to. They will say like one is better than the other. If it's Dr. Barbara Peloni or Dr. Hassan Motada, it depends on whom we speak to. They will say what they do is right. But in my opinion, if it's the depth of the posterior staphyloма, if the staphyloma is very deep, then probably sometimes you may not be able to, the buckle may not work. And I have not done buckle as a primary surgery in a macular hole with a myopic detachment. So when I have done this, like if there is a recurrence and if there's a macular hole with the macular detachment and a large posterior staphyloma, then I add up the macular buckle. Otherwise, like usually I try with the vitrectomy, and if it doesn't work, is when I put a macular buckle. That's how I have gone about it. And very often, like you would think that like the key in macular hole in myopic detachment surgery is the staining. As I mentioned, very often, like in very, very experienced hands, you would have left behind a posterior hyaloid. You would have thought that the posterior hyaloid is removed, but there will be a hyaloid posteriorly. So in these patients, yes, stain with triamcinolone. Then after staining with triamcinolone, you will find that thing, and like you will find that hyaloid, which will incise with the needle, then peel gently with the forceps. Then do an FGE and put the BBG under air. So this is one of the select situations where I stain the ILM under air, because in myopes doesn't stain too well. So put BBG under air, leave it for a minute, make sure that the ILM is stained, then peel that ILM as well. Once the ILM is peeled, then we are sure that the posterior hyaloid is removed. So this increases the chance of success. And if it fails, and if there's a macular hole, as in that case which I showed you, and a very deep staphylomas, then I would consider putting a macular buckle.
In high myope, every step is a problem because your probe might not reach to the staphylomas posterior part. So just without a PVR, a macular hole with high myopia cause of the RD, yes, buckle is a preferable choice. But in a vitrectomy, the problem is as staining is difficult because there is no contrast because of the staphyloma and the myopic CRA. So the staining is it's very difficult to see the stain, which layer you are peeling. Retina is thin in the posterior pole. So many problems, and the probe cannot reach to that extent. So if possible, and if you are trained well versed with the macular buckle, better. Otherwise, yes, we don't have a choice. And even a retinotomy, because sometimes you don't want to drain to the macula, so you want to drain elsewhere. And if the contrast is not clear, then you cannot see the laser reaction as well. So whether the laser retinopexy has been done or not, it's very difficult to predict. Myopic is always a challenge.
Dr. Anju, your comments about the talk?
Sir, it was a very exhaustive talk. I learned so much. Thank you so much, Mahesh sir. It was really exciting to, like, we have experience basically speaks a lot. So thank you so much for that.
Thank you all for your kind words.
MPS sir, I would like to ask one question. In buckle, somebody has done the segmental buckle and put the 360-degree encirclage. Now there is a migration of 360-degree encirclage, 3 to 4 millimeter posterior to the limbus. What to do? Whether should we keep it there, whether to remove or whether just wait and watch?
It depends on how long since this buckle has been done. Sometimes this happens about like 10 years, 5 years down the lane, and it's a very slow progression. And you can leave it unless it's cosmetically disfiguring. Sometimes it can be so anterior that it can be cosmetically disfiguring. So if it is so many years down the line and the buckle is not serving this purpose, you can remove it. Only concern is whether it has dug into the sclera. So when dug into the sclera, like dissection and removing can be, you need to be careful if it's a particularly myopic eye. We don't want to create like a rupture of the eye on the table. So that's something which we need to be concerned about. So if it is not cosmetically disfiguring and the patient is okay with it, you can leave it alone as well. So there is no hard and fast rule. So it is not serving the purpose. You can remove it if you think it's safe to remove it.
So I wanted to ask one question regarding if a patient comes with a suprachoroidal hemorrhage with RD and it's a fresh suprachoroidal, how would you approach the case? What time duration and when to intervene?
Suprachoroidal with RD, it's a reg RD with a break. Any reason for the suprachoroidal hemorrhage, Dr. Ganesh?
So suprachoroidal hemorrhage along with RD has happened.
That's what, like any reason both have happened together. Usually when this happens, it's usually a PHCR or an exudative detachment or a post-trauma or something like that. So it's like,
post complicated cataract surgery.
Okay, so if what I do now is to like it depends on where the break is. So if it is a needle perforation or something like that, and if it's away from the suprachoroidal hemorrhage, then we can go ahead and tackle it and inject subretinal TPA and come out also. But otherwise, like you can inject TPA, wait on the table for the hemorrhage if the hemorrhage is not liquefied. So if the hemorrhage is liquefied at about a week to 10 days after the trauma you are taking in, the hemorrhage is usually liquid, then you can do a like retinotomy and then drain the blood and then reattach the retina. If it is still clotted in the acute phase, then we can probably inject TPA on the table itself, provided the needle perforation has healed to some extent. So earlier days we used to do this only. Inject like a TPA into the subretinal space, wait for about 45 minutes, that will liquefy the blood, then drain it with a properly placed retinotomy and then putting a perfluorocarbon over the posterior pole and rolling the eye towards the retinotomy so that the liquid blood will come out, then reattach the retina and do that. So one of these two options can be done. And the earlier it is done, the better, because like one is like your own patient, you don't want, if in case it's your own patient, you want to give the best results possible. But again, this has to be balanced against whether it's just a needle perforation has gone in and come out and it's unlikely to open during the surgery versus a scleral laceration, which may open up during the surgery. So if it's going to be a laceration, then you would probably want to wait for about a week for the laceration to heal and then take it up for surgery.
Yeah, thank you, sir.
So one more question about the buccal. In a moderate RD, moderate height RD, how much cryo is enough? Means whether we should cryo till we see the cryo effect on the retina, or we should do only the cryo of the choroid only and RP.
Not necessary to all the time the ice ball need not reach the retina. So if we are able to depress it sufficiently that like retina is almost opposed to the RP, then we can wait for the burn to come to the retina. Otherwise, like when cryo the RP and leave it. The only problem is like cryoing the RP doesn't give the same strength, choroidal adhesion strength as cryoing the retina. So that is the only difference. But like it's just like if instead in the if you want to avoid excessive cryo, yes, cryoing the RP is adequate enough.
Thank you, sir. And the extension of my first question was, so that case in which the buccal migration, the encirclage migration anteriorly was there, is there. The case was operated 6 to 7 months back. Buccal surgery was done. After that, re-RD was there. Then I did the vitrectomy, and a couple of days back I removed the oil also. But the buccal migration is still there, 4 millimeter posterior to the limbus. I have not touched the buccal, the encirclage. Sorry, I have not touched the encirclage, but it is hardly 4 millimeter from the limbus. So how long should I wait and watch? And what are the indication to remove that encirclage?
As I mentioned, it is not serving the purpose if it's 4 millimeters from the limbus, so it's not supporting the vitreous base, then you can go ahead and remove it. And yeah, there is no need. As I mentioned, the indication for removal is if it is exposed, if there is a transconjunctival exposure of the buccal and there is an infection, yes, we would definitely remove it. But if it is a subconjunctival space and if the patient is cosmetically not disfigured by that, not bothered by it, we can leave it. Otherwise, we can go ahead and remove it. And this buccal migration is a very peculiar thing. Like actually, like we tend to think that it actually cuts through the muscle. So the muscle is not disinserted, but the muscle, if you go inside and see, the muscle will still be attached to the same place, but the buccal has come anterior to it. So it kind of it happens, seems to be happening in a very gradual like way. At one area, the muscle gets disinserted, then gets reattached, and the other area muscle gets disinserted, the buccal moves anteriorly. So that's something which is peculiar, which happens.
Yeah, sir, the picture is almost same. I was not able to find out from where the buccal has come out through the muscles.
Yeah, that's what we tend to assume, that like it has migrated through the muscle insertion, the muscle is disinserted, reattached itself in kind of a graded fashion. That like the buccal is able to come anterior, the muscle still is attached to its insertion.
Okay, sir. Thank you. Dr. Janani, other questions? You have a lot of questions for sir.
So my questions are very simple, sir. That's why. No, sir, for a simple RD, so when do you remove oil, sir? I think every beginner must be having this question. It's any hard and fast rule, sir. If there is no PVR, not one night, it's not a heavy oil.
Usually 3 months, but if in case the patient has a glaucoma or any other risk factor, then I may remove it even as early as like 1 month also, 15 days to 1 month also, because by about a month, the choroidal adhesion is taken over. So at the end of 1 month also, we can remove it. Like, I don't know where this 3-month number came up from also, but like you can remove it as early as 1 month also. So 1 month to 3 months is usually when I remove it.
Yes, sir. And many a times intro and first week, I still feel I have done the oil fill is adequate. But when I see a glass appointment or later, I feel sometimes, especially after I think doctors has come, the underfill, I think we are noticing it more. So it is like due to incomplete vitrectomy or like any specific things, but not in all patients, but some patients it's like really gross underfill. Is it related to adding belt buckle also, or?
The oil underfill can be due to multiple reasons. Incomplete vitrectomy, possibly one of the rarer reasons, but we would do a reasonably okay, I think, basic excision. But like an incomplete FG is what happens actually. So if you're not able to completely drain the fluid and there is some fluid in the preretinal space and the subretinal space, and we tend to, and again, when you fill the oil, we want that there is no accurate way of measuring the IOP. It's usually digitally. We tend to think, okay, it's adequate, it's not adequate. We tend not to overfill. We don't want a glaucoma. So these are the reasons. Like in the meantime, what happens? Some amount of the fluid which is trapped in the vitreous base again goes back. So as we inject oil, so that also creates a space. So which causes the what do you call it? So insufficient fill of the oil. But I'm not bothered too much about it if the oil is not doing its work. If the break is superior, then it's absolutely no issue. If the break is exactly at 6 o'clock, then that is when we'll be bothered about the insufficient fill. So if it's a 6 o'clock break and the anterior hyaloid I have not separated, then I would still put an encircling band. So that way I tend to counter this insufficient fill. So insufficient fill, yes, it happens to be very often as well. But as long as the purpose of the surgery of tamponading the breaks is adequate, I'm not worried about it.
So adding to the simpler question, sir, what is the end point of your oil fill? When do you determine that my oil fill is complete or it is sufficient? And do you keep some IOP on still, say, 5 mm or 10 mm of HG at end of the fill, or keep it 0 at the end of the surgery, sir?
The way I do it is like I do an FGE, then reattach the retina, then remove the fluid from posterior pole, and then start injecting the oil. And once the oil reaches the infusion cannula, you can see that bubbling up there. So once that reaches the infusion cannula, then the sister cuts off the air. So that little bubble of the air which is there, then I use a fluke to remove it. And again, as I mentioned, there is no correct way of like feeling the IOP. It's like digitally, if I feel it's okay, I leave it. I usually leave it a little bit softer rather than like harder. That's what I do.
Yeah, Dr. Atul.
No, sir, I want to ask one question related to the buccal. That how much drainage is necessary in a case of the means the very severe bullous RD? How much drainage is enough? Should we take out all the fluid or just half of the fluid, or how much means drainage is necessary?
Actually, no drainage is also it's okay. So if it's a superior break and bullous RD and macula is detached, then you can place the buckle in the correct place, inject a bubble of air, and that's adequate. So you don't have to really drain. So how much is necessary is sufficient for the break to sit on the buckle, and the margins are well seen. That is in a HST and an inferior break. Superiorly, you really don't have to worry. So if it's an inferior HST where you want the HST on the buckle, so you can make sure that it's on the buckle, and there can be fluid posterior to it. Actually, sometimes I leave the fluid posterior to it because next day morning, if the fluid is gone, then I know that this patient is going to do well. This patient is not going to recur. That means I have not missed a break. So I use that as a way of a kind of a diagnostic challenge as well. So if the break is closed, inferiorly, I leave behind fluid posterior to the buckle. If the fluid is gone next day, you know that this patient is going to do well, unless the patient develops a new break. So you're not missed a break. So that's adequate. Not necessary to drain it dry.
One more question, sir. Because I am draining from the primary break. That's why when I'm doing the primary break drainage, many a times I'm seeing that the fluid is accumulated at the end of the surgery on the posterior pole. By this, okay, I usually keep the fluid like that, and on the next day the fluid is absorbed by the RP pump. But I am seeing a thin layer of fluid between the buccal, band buccal, and the oil margin inferiorly, most of the times. So how to avoid this? Should I inject more oil for the couple of days, which will replace the fluid, or how to manage this situation?
So the fluid is under the retina or in the preatrial space?
No, under the retina, because the I am draining from the primary break, which is near to the aura, and I am tilting the eye and I am taking out most of the fluid, maybe 80-90% of the fluid, but 10% of the fluid still is there on the posterior pole at the subretinal space.
Yeah, if it is like, if you're going to use gas tamponade and the posterior fluid is there, then I would just leave it alone. That will get absorbed the next day morning. That's okay, because your break is very anterior and like it's going to be tamponaded very well with the gas bubble. And like, so a little bit of fluid in the posterior pole that gets absorbed. So if it's only the inferior break at 6 o'clock, then you would be concerned about it. Sometimes what I do is like, if it's an inferior break at 6 o'clock and there's no PVR and a primary vitrectomy kind of situation, you can ask the patient to maintain supine position also. Because supine position, then the inferior break gets tamponade also. You don't have to maintain a prone position, in which case the anterior-most break in the 6 o'clock may not be tamponade. So you can ask the patient to maintain a supine position. The only problem is the patient may develop a cataract if the patient is a phakic patient. That's one risk. So you can ask the patient to maintain a supine position, which will tamponade the inferior break. So I'm not really worried about the fluid in the posterior pole. If it is a primary RD kind of a situation and there's no PVR and it's going to do well. So if it is an inferior break with some amount of traction left, then I would have, as I mentioned, put a belt buckle also. So that will take care of the another additional safety factor it gives me. So depending on what the situation is, the management will vary. If it's a 6 o'clock break, then most of the time I would have put an encircling band. So the encircling band pushing it from below, the oil from inside, so it usually takes care of it. I'm not sure if I've answered your question correctly, appropriately, Dr.
No, thank you, sir. Thank you, sir.
Thank you so much, sir, for a wonderful presentation and all the tips and tricks that you have given in management of RD. I would like the closing comments from Dr. Kasinathan, sir, first.
As I said in the beginning, it's the ASG team is too greedy to have the entire VR surgery in just 1 hour. but it's nicely precise and nicely concise by sir. No one none other than sir can do it within an hour. So a lot of tips. Each topic by itself is a discussion for more than an hour. But sir has very nicely made it very precise and concise tips, and lot of tips in a vitrectomy buckle. And as I said, buckle is an art. And for a buckle, you need to be good at indirect ophthalmoscopy, and not to forget, you need to have a good assisting nurse. If you have an excellent assisting nurse and you're good at it, your skills and indirect ophthalmoscopy, buckle is the best surgery, I would still say. And otherwise, vitrectomy also said a lot of tips, and it's a very nice, well presented, and learning is a continuous process. I learned from sir my vitrectomy and buckle, and still learn more things today as well. And thanks to Team ASG for having such wonderful master classes.
Thank you,
Thank
sir.
you, Dr.
Thank you.
Kasinathan, for your comments. Dr. Janani, your closing comments.
Thank you, sir. It was a very nice session. I think it's the best way to put up. And Kasi, sir, your inputs also. Thanks a lot, ASG, for organizing things. And thank you, Atul, sir, for involving me in this.
Dr. Aarifa.
Thank you. I would like to thank ASG team and Dr. Ganesh, Dr. Atul, everyone for inviting me to be a part of this wonderful discussion. It has been a great 1 hour discussion, and hopefully in future we can have more subdivision of these topics, scleral buckle alone or vitrectomy alone, where we can discuss more things in depth. But overall, it was a wonderful session, and it has been very enriching as well. Thank you so much, Mahesh. Thank you, everyone.
Dr. Anju and Dr. Atul, please.
I would like to thank Dr. Mahesh sir for such an excellent talk, Dr. Kasinathan sir for such a interesting discussion, Dr. Aarifa as well as Dr. Janani. Special thanks to Atul sir for inviting me for this, and it was a great session. Thank you all.
For me, most of the time when I'm in trouble, I'm calling Kasi sir, and sometime also I'm calling to MPS sir also when I'm in the difficult situation, and I'm learning every time from each and every word from both of them. So it was a great lecture, and I hope we'll have more from sir and Kasi sir in the future also.
In the end, thank you, Mahesh sir, Shanmugam sir, for honoring us and gracing the occasion. It was wonderful to listen to you, each and everything that you have described in detail, probably in a very short span. It is a learning in itself, and I would like to have you more often. And most of the fellows who were here attending, they learned a lot from you. So keep providing us the opportunity to host you whenever you can, sir. Thank you so much, sir.
Dr. Ganesh, can
you
you
all.
tell me, Dr. Ganesh, can you tell us about the next session also? Brief.
Dr. Atul, please.
The next session is by Dr. Ulrich Spandau, and he's from Sweden, and he will take a lecture on PVR management. The panelists will be Dr. Wilson Wong from Malaysia, Dr. Dipender from India, and then Dr. Ekta Rishi from US, and from our side, Dr. Kaushik will be there. So that's going to be the next master class from the ASG.
Thank you, everyone. Good night, sir.
Good night, sir.
Thank you very much. Thank you all. Good night.
Good night,
Thank
sir.
you all.
Good night,
Good
sir.
night.
Good night. Good night, sir.
Bye. Bye.
Bye, sir.
Bye bye.
Bye, sir.